We are live now.
So, good evening, everybody. A warm welcome to all of you on behalf of IAGE. Thank you for taking the time to join the session on optimizing operative hysteroscopy. So, as gynecological surgeons, we know how small technical refinements can make a big difference in the patient's outcome. And today is about sharing those insights, the tips, the pitfalls, and also the small pearls that elevate everyday surgical practice. So, we are delighted to have you with us, and we bring together evidence based practice and real world surgical expertise to help you perform safer, faster, and more effective procedures. So, I would like to welcome our President of IAG, Dr. Kalyan Bamde, for giving the welcome address, please. So Dr. Kalyan Bamde, I believe, is traveling, so he will join us shortly. So he is actually he was the chairperson of Infertility Committee and also the Public Awareness Committee and Executive Council member of IAG 2011 to 2025 and current president of IAG, and also the Maharashtra Izar, president of Latur Ops and Gynac Society, organizing chairperson of AMOX, and also organizing secretary of MRCOG, and he was the organizing secretary of the first Yuva IAG 2017, and many more to his accolades. So we seek the blessing of our Almighty to start this webinar for a smooth transition. And today the convener for this program is me, Dr. Malaraj, and our coordinators are Dr. Piyush Vora and Kajal Parikh. So, of course, this is me. Currently, I am the vice chairperson of IAG TN chapter, and we have a coordinator Piyush Vora, who is the consultant and laparoscopic surgeon from Jammu and Kashmir, and he is
From Himachal Pradesh, ma'am.
Oh, sorry, from
Up
Himachal.
north, though, yes.
Okay, yeah. Then he has completed his post graduation from Chandigarh, and also FMAS from Amira Healthcare Laparoscopic Center, fellowship in advanced gynecological endoscopy. So we have a very young and budding endoscopic surgeon here with us, and who is also a youth council member of IAG and has won best gynecologist award by the Society of Scientific Research and Studies in 2022, and has various other accolades at this age. So welcome to you, Dr. Piyush, and welcome to IAG as well. So next,
Thank you, ma'am.
We have another young and dynamic endoscopic surgeon, Dr. Kajal Parikh, who is also very good endoscopic surgeon from Breach Candy Hospital, Bhatia Hospital, Saifi Hospital, Elizabeth Hospital, and various other places. So we have these two young endoscopic surgeon who would coordinate this session. So now I hand over the session to our coordinators to invite the chairpersons, and to the chairpersons would invite the speakers. Yeah.
And I assume Dr. Kajal is apparently
Yes.
not.
So you can.
She has
Hi,
not
can you hear
joined.
me?
Yeah.
I am right here. Can you hear me?
Okay.
Yeah, Dr. Kajal.
Yes. Hi. Very good evening, and thank you so much, Dr. Malaraj. I wouldn't take much time, but this is a fantastic series that's been going on. And here I'd introduce our first speaker, Dr. Anuja Kulkarni, madam, who is an endoscopic surgeon, a senior consultant at Latur from Mamta Hospital. And her affiliations are: she's a past president of Latur Obs Gynac Society, past president of IMA Women's Wing Latur, a life member of IMA Foxy IAG, and has special interest in vaginal surgeries, lasers, and hysteroscopic surgeries, and has presented papers as national and international conferences. And she is the winner of the Suli Singha Award AICOG 2005 in laparoscopic management of ectopic pregnancy. Over to you, madam. Dr. Anuja Kulkarni.
Yeah. So, Dr. Anuja can introduce Dr. Sudha Tandon, the speaker. Dr. Anuja, are you there?
Yeah, sorry, I was not able to unmute myself.
Yeah. Okay.
Thank you, Dr. Kajal, for the introduction. I'm the chairperson for this session, where Dr. Sudha Tandon, who is the senior endoscopic surgeon and IVF consultant working at Sudha Tandon Fertility Center in Chembur and Navi Mumbai since last 25 years. She is the vice president of IAG at present, and has been the committee member of MOGS and ISAR. She has organized many conferences and also been invited as faculty to many conferences. She's an incredible surgeon. I have seen her surgeries, and she also takes the credit of training her two beautiful daughters, Amrita and Aditi. So, over to Dr. Sudha Tandon, madam, for her talk on how to negotiate the cervical canal in difficult surgeries for hysteroscopic surgery. Thank you.
Thank you, Anuja, for your kind words. And thank you for taking the time out for this. So I think it's a beautiful webinar that we are having on this important topic, because hysteroscopy is now being accepted much more than what it was. And we are getting more of, challenging cases where we have this. Am I audible?
Yeah, very well, ma'am. Yeah.
Yeah. So, so we do come across challenges. We would know how to do a myomectomy, how to do a polypectomy, but unless you enter inside the uterine cavity, you would have to cancel a case. So let us see what are the techniques that are available to navigate the internal os. So now we all have shifted to the vaginoscopic method, and this is the gold standard, and it has lots of advantages. And because we can see the vagina, we can see the cervical pathologies, and this is you're entering the uterine cavity under vision as compared to entering it blindly, and you can see the entire uterine cavity, endometrium, the ostia. So the vaginoscopic method really scores over what we were doing initially, holding the cervix and then entering into the uterine cavity. But these are the issues that can really prove to be very challenging, and we need to know how to navigate it. Most important is cervical stenosis, especially in infertility patients and in patients of postmenopausal bleeding. These are the two important cases where this we come across. And then there could be other obstacles. We'll see them as we go through the false passage and uterine perforation. It can happen in a first case, it can happen in a thousandth case also. So I think you have to be very watchful in all cases that you do, in every case that you do. Okay, so now this is quickly, we will see this video going into from the external os into the cervical canal. At the internal os, you enter inside. This is an oblique slit, the internal os, and then you enter into the uterine cavity. You see both the ostia. If everything is fine, you can actually finish a diagnostic hysteroscopy in less than a minute. So this is about it. Of course, we are not talking of the surgical part. So now, what are the main issues or reasons of failed office hysteroscopy? And that can happen even if you're doing hysteroscopy under anesthesia. And this is basically severe cervical stenosis. And this is the main reason: pain and cervical stenosis at the either it could be external os, cervical canal, or internal os. And how do you manage this? So this is the cause of pain where you enter. Now, so cervical stenosis can be congenital or it could be acquired. Now, acquired is, as I told you, in postmenopausal. This lady comes with postmenopausal bleeding and you want to evaluate, but you're unable to put your scope inside. Use of progestrogens, nulliparity, infertility, previous curettage, cervical surgery, infections, premature ovarian failure, and I think also in cases of where you have intrauterine adhesions or Ashermans, where a very tight internal os, and quite often you come with a patient diagnosis or with a discharge paper where the previous surgeon has failed to enter into the uterine cavity. So now we must remember that the operative what we have, either the scissor or the grasper, is 5 French forceps with teeth, and you have 5 French scissors, or you have 5 French bipolar electrode. The entire assembly is 4 millimeters, or with a resectoscope it comes to 5.5 or 6 millimeters, and the hysteroscope by and large is 2.9 mm that we use routinely, and this would be not difficult to enter in almost all cases, but few cases we are unable to. So this has been classified. There's a classification of cervical stenosis where you have type 1, where you have stenosis at the external os. Then you have type 2, where there is stenosis of the distal part of the cervical canal and the internal cervical os. Then you have stenosis only of the internal os, and then you have a type 4 is a combination of everything. And let's see which are the cases that you find these more commonly seen. Now this, how do you overcome? What is the first technique is, you must remember, you're entering into the uterine cavity by under vision, and the cervical the internal os is not a circular thing. It is it is the whole assembly that you have is oblique. So you can just use little bit of, like you use this to dilate and to break the flimsy adhesions to enter with this oval instrument that you have. So this is the first technique, is you try to maneuver it by moving it in a clockwise and anti-clockwise direction and enter inside the uterine cavity. Little force that you have to use at this time, and you will be able to enter, provided it gives way. If it does not give way, then this is the second technique we'll see in the video. You see the small internal os. You can put the grasper through the operating channel and just try to negotiate it in a closed grasper. And then once you're inside, you can slightly open it and stretch. Now, this would be only possible under when the patient is under anesthesia, not because otherwise it will be quite painful. So this is the second technique. The third one, if this also does not work, if the graspers don't work, then you can use scissors to cut the few of the adhesions around. And like you see here, you cut the adhesions, make small nicks. You can make it transversely or on all four directions in the form of a cross, and then it gives way. You can also do the same thing of cutting. Instead of scissors, you use the bipolar needle electrode and make the incisions. You go upwards, then you go down at 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock positions, and just small incisions as shown in this video, and then it opens up. Now, it's important that when you are at the internal os, you wait for the pressure, either the Histromat or whatever you are using, for the pressure to mechanically also dilate the internal os. Just wait for a minute, maybe increase the pressure, maybe increase the flow, and then you will see the internal os. So this would help. And once you see that the internal os is open, then you can negotiate your uh, internal os. So this is few techniques. Now let us see. This is one of the videos in one of my patients, postmenopausal bleeding. It looked very simple. There was a nice polyp which was coming out. So I have tried to go in right with my resectoscope, right? You have to go around the polyp and see from where it is arising, and also see where you have to enter into the uterine cavity through the internal os. So you have, this is the internal os. Can you see? And this is no way that I would be able to enter with a resectoscope. So then I have used the operative sheath and the grasper to mechanically dilate the internal os, because unless you do that, you have to enter the uterine cavity and see where the polyp is arising. So if you see here, the polyp is arising, though it was seen from the external os, it is arising right from inside the uterine cavity. Then you can grasp it, twist it, and take it out, or use a resectoscope and then take it out. Can you see that? Yeah. So I've cut it with a scissor, and then we'll leave little bit at the base, and then take out the entire thing with the assembly, with a grasper, take out the entire assembly. So otherwise it will be lying freely into the uterine cavity. So this is extremely important, and this, it was not coming with that, and hence now you put in the resectoscope and resect it from the base. So each case would be different and you have to tackle it accordingly. So this is a very good study where they have evaluated the hysteroscopy in the issues about cervical stenosis in the fertile woman and in the postmenopausal woman. And it was a retrospective review. And what did they find? That it was successful in most of the cases where they were able to enter the uterine cavity and see both the ostia. So that is how it was termed as successful. It was not, it was incomplete where you enter into the uterine cavity, but the entire uterine cavity could not be examined either because of some anatomical problem or patient's reaction. Failed is where you could just not enter. So if it's incomplete, you may do it later, or if it is failed, you could do an ultrascope. You use an ultrasound guided hysteroscopy and use general anesthesia. Now, so it was seen that in 93%, almost 94% of the patients, it was successful, whereas 4.3, it was incomplete, 1.9, it was failed. These were the results. And which of the cases, what was more commonly seen? In infertile women, or when infertility was the issue, in 30% was the total uh, issues that they came across cervical stenosis, whereas 70% in postmenopausal. And if you see, the combined form type 4 was more commonly, was more often seen in the postmenopausal women, and the type 1, the external os uh, being not negotiable, was more commonly seen in the fertile woman as compared to the postmenopausal woman. So then this definitely could be a challenge in postmenopausal patients. So which techniques helped in type 1, where you have rotation of the scope from 3 o'clock to 9 o'clock position to enter, and also sometimes it's antiverted, so you have to put your scope down, absolutely down. Otherwise, if it's retroverted, you have to put your telescope up and enter in the retroverted manner. So this rotation of the scope was quite successful in about 15 to 30%, whereas the technique 2, where you use a grasper, was also more commonly was in the other about 50%, and scissors were used in other few, about 25 to 30%. So this was what the techniques which helped in type 2 and type 3 cervical stenosis. And what was the conclusion was that the cervical stenosis was identified, was significantly more seen in postmenopausal as compared to fertile women, and type 1 stenosis was more commonly seen in the fertile woman as compared to the type the 4 one. Type 4 was the most commonly detected, and by rotation of the scope on the endocamera was about 40% helped, and the others, they were used type 1 and type 4 stenosis was by the other techniques, was what was the final conclusion of the study. So that was about the technique of entering. What about the other use of misoprostol? I think the opinion is varied about misoprostol. There was a time when we were using misoprostol in all patients. Only issue is where it suppose if there's a submucous fibroid and if the os is already open, then there's so much of leakage that you do not get good distension and you cannot operate. But I think sometimes in postmenopausal patients and in patients with where there are bad intrauterine adhesions, where you suspect or you know that this issue is, I personally feel misoprostol would help in these patients, but the opinion is divided among hysteroscopists. I leave it to an individual surgeon, but in selected cases, I feel it is of great help. And whether you use 200 or 400, it has to be administered at least 5 to 8 hours before the operation, before you do the hysteroscopy. So I think choose where you want to use vaginal misoprostol for cervical ripening. I just did a hysteroscopy. I don't have the video today of a patient with very bad Asherman's, and the previous discharge paper had that they were unable to enter the uterine cavity. So I used misoprostol in her. I still had to use the technique too for entering, but at least it was possible. It was a little softer as compared to when you don't use it. So I think it's your discretion. Now, which are the other techniques? Now, this is where you use dilute pitracin. You can use 20 units in 200 ml in still paracervical at 10 and 2 o'clock. Please tell your anesthetist, always aspirate, be very watchful of bradycardia and cardiac arrest, and be extreme. If you go into a blood vessel, please don't inject. And this is quite useful, especially in patients who have a submucous fibroid. Would you like to do dilatation? Again, I leave it to the individual surgeon. If they are comfortable and they are confident, then this could be used because you are more familiar, or as gynecologists are more familiar, but I would leave it to the individual surgeon to decide whether they would dilate or they would not dilate. So which there are some pathologies which are present, which cause an hindrance to the internal os, and how do you tackle it? Now, this is anterior crypt hypertrophy, polyps, and myomas, and these cause a big issue. You are unable to do your IUI, you are unable to do an embryo transfer. So this is a beautiful video. The endocervical crypts, they converge and shallow down towards the internal os. In 30 to 40% of the patients, anterior crypt is dominant. And this, you take this patient for IUI and ET, and you would not be able to do it unless you have corrected this. So this is a beautiful video where this anterior cervical crypt is resected. They're trying it with a grasper, not happening. And this is where they have used a resectoscope to resect it. Only issue with any intracervical problems or issues during hysteroscopy is that the distension you don't get as compared to when you're doing an intrauterine pathology. And you have to be extremely good with your resectoscope. And once you are finished with that, then you can visualize the internal os and then enter into the uterine cavity with the diagnostic hysteroscopy or operative, depending on what the pathology is. So this problem is the reality, and one needs to tackle it. So just see how the internal os opens under pressure after you have resected the cervical crypt, and then a grasper is used again to open, to negotiate, and there you are inside the uterine cavity. So you have to have everything handy when you're doing hysteroscopy, and there's no the way that you can, not have all the instruments. Now, this is one patient where there was an anterior cervical lip polyp. So if you see here, so you have to hold your assembly very well. You should know that the camera should be facing at 12 o'clock position, because you should be very, very sure of where the pathology is, which wall the pathology is. And if you see here, you see, this is the anterior cervical lip polyp, and resect it. And then you enter into through the internal os into the cervical, into the uterine cavity. So this is how it is beautifully seen. Now, if you see here, this is a polyp arising from the internal os. It's very tempting to hold it with an artery forceps, twist it and take it out, but you would not do a good job or a complete job, because you have to resect it from the base. So reaching the base, visualizing where it is arising from is extremely important. And you see the os is beyond the where the polyp is arising from. This is where it is arising, and the internal os is just beyond it, and then you can see, you can enter inside and do visualize the uterine cavity. So this is the video. Now there could be, I have about 5 more minutes. I'll just quickly finish. How do you identify a false passage? And mind you, we were doing blind dilatation, and quite often we may have been in a false passage. See, here is the false passage, and this is the uterine cavity. So your internal os and the two ostia are is what these are the landmarks in hysteroscopy. Unless you have visualized that, you should not be doing any surgeries. So extremely important. So you have crisscross myometrial fibers with pulsating blood vessels if you are in the false passage. And if you reduce the intrauterine pressure, that will be filled with blood. Okay, so this is, if you see the false passage, and then this is the uterine cavity. So what you need to do is, when you're into this muscle, you take out your entire assembly, take a panoramic view, and again visualize this and come into your uterine cavity. Okay, so this is what is seen in this video. Yeah, so this is the false passage. You come out and then enter into the uterine cavity. So your internal os and the ostia. All right. So uterine perforation, you'll lose your distension, you might see the omentum, and you'll suddenly, the whole bottle of fluid will be inside the peritoneal cavity, and you'll have abdomen which gets distended. So which are the perforations that you warrant laparoscopy? With a resectoscope, definitely. Perforations you can even do with your own forceps when you're retrieving the pieces of myoma chips. And lateral metroplasty and excessive bleeding, these are the cases which will warrant a laparoscopy. So is it possible to do hysteroscopy after perforation? Sometimes yes, if it's very small, with a scissor, at the fundus or at the cornu. Then if the pathology is below, you can still manage, but you should be very quick and confident and very sure of the perforation, and finish the procedure in less than 2 to 3 minutes. Patient has to be stable, and you should not do it if the patient is not stable. So increase the pressure, it will seal the perforation, and you may just quickly complete the procedure and come out. So when you will avoid a laparoscopy, perforation with scissors, which it's with a scissor, it's extremely small, and there's no need to do a laparoscopy. And if you increase the pressure, the perforation seals. This is not what I'm recommending for a beginner, especially if you are very good in your hysteroscopies. You can, otherwise best is to not not continue with the hysteroscopy. Asherman syndrome, extremely very high risk for perforation. The because you would not know, because you cannot see the two ostia. You would not know whether you're into a uterine cavity or in a false passage with adhesions. So the internal os could possibly be a place where you will be able to, okay, now I'm entering into the uterine cavity, some sort of a triangular shape that you'll come across. And also in Asherman's, I feel the uterus is little softer as compared to a normal uterus. Fundal, huge myomas, and you have small pieces you're taking out with, and it's a very huge uterus, and you can perforate with your own forceps. Lateral myomas, previous uterine surgeries, infantile uterus, and postmenopausal patients, though they could be a polyp, but the whole uterine cavity is small, remember that. So it will not be, you have to be very watchful when you're entering into a postmenopausal patient. These are also very soft uterus. So if there is a perforation, do not panic. Do not come out of the uterus immediately, because at least um, see to it that your recording is not stopped, because you'll want to stop the recording and you'll not really be able to really present it or learn it for yourself later on. So do not panic, let the recording continue, and do not come out of the uterine cavity. Stop the fluid, check for the site of perforation for bleeding, check her vitals, check input output, check the secretions if it's blood or mixed with stool, call for help, very important. And if the vitals are maintained, conservative management, you could do a sonography 4 hours later to check for fluid levels. And point to be made here, which the furosemide or Lasix works even for extra corporeal fluid. It's not only for if there's increase in the fluid intake. Even if the fluid is in the peritoneal cavity, your Lasix would work. Keep the patient in the hospital and observe her vitals and check her vitals and put in a catheter to monitor her urine flow and how she's feeling. And I take this opportunity to invite you for the Endogyne, our IAG annual conference 2026, which is from March 20th to 21st, 2026 at Calcutta. And there are a lot of uh, uh, good sessions which we are planning and live surgeries, and I'm sure everybody would love to come to Calcutta. So inviting you all for this national conference. And the most exciting part is that the new team of IIG gets installed during inauguration, and I would be taking over as president. Thank you very much, Dr. Mala and your entire team, for this opportunity. Thank you, Anuja madam, and everyone. Looking forward to seeing you at Calcutta. Thank you.
Thank you, Sudha madam, for a wonderful talk and especially very nice videos for showing how to negotiate the steno cervix in difficult cases, especially the vaginoscopic entry and use of instruments like graspers, scissors, bipolar, and use of misoprost and vasopressin, and also how to tackle if you've made a false passage and perforations. What about questions, Dr. Mala? Are we going to take any questions? We cannot hear you. You'll have to unmute yourself.
Mala, you'll have to unmute. Hi, Sudha.
Hi, hi.
Nice presentation. I had seen it in
Yeah.
this. Very nice.
Very
Yeah.
nice
Yeah.
videos.
Very, very nice presentation. That's why I wanted Madam to address the same thing. Thank you so much, Madam. I think we will take the questions now
The problem is only the network.
because Madam would be leaving now. So, are we having any questions in the chat
Yeah,
box?
sorry, I have few appointments.
Ah. Yeah, okay, fine, Madam. Yeah, yeah.
There are any
Yeah, okay, ma'am. So that was a very excellent presentation. In fact, all the various types of methods by which you can dilate the cervix, we have you highlight. So this cervical stenosis, as we all know, is one of the most challenging barriers for our hysteroscopic surgery. But then with the advent of all these techniques, we are able to somehow manage and get into, which was beautifully demonstrated in all your videos. Videos were very good. And also, how about the role of ultrasound guided entry, madam? How, do you find that useful for entry?
Yeah, it is a useful technique. But when you have started your hysteroscopy and you're unable to enter, then if you have to do sonography, you have to wait for the bladder to be little full, then have some sonologist or somebody in your team to do the sonography and guide you. So that would take, even if you're using fast IV fluids and Lasix, it would take at least 15-20 minutes you have to wait. Where I feel this is under vision and you can
Yes.
do it. But of course, it's an option that one can think of. Or if you're contemplating that your entry is going to be difficult, then you keep the sonologist and the sonography machine in the OT, like you would do in few MTP cases, and it would help you. But the bladder being full will straighten an anteverted uterus.
Yeah, yeah,
And otherwise, if there is a cervical stenosis, I don't think it would really help.
yeah.
And also your cervix will go a little farther away from you.
Mm.
If you're using vaginoscopic method, it's fine, but if you're holding the cervix, then it goes a little away and for you to visualize the cervix. So these are the practical difficulties. Of course, it's a very good tool. One should keep it handy.
Yeah. So someone has asked, like use of injection Buscopan. Will it that be helpful? use of buscopan in the cervix?
Not
In the
really.
cervix or
Buscopan
systematically,
or
IV?
people used to use epidosine and buscopan whenever
Mm.
there is a, we are doing diagnostic hysterolaparoscopy for infertility. What I do is if I am not able to negotiate the internal os, I'll abandon the procedure. I start with the laparoscopy. You give prostaglandin 125 milligram, what we use prostadine. You complete the laparoscopy procedure and in 10-15 minutes you come back and start hysto, you will find the internal os open.
Okay. Prostadine you give.
Yeah, so that's really, it's a nice drug, but you wait for 10 feet. Meanwhile, you finish your laparoscopy part
Yeah.
and then come back and you will see that, the os is nicely open and that's how you can use it.
Right, right. Okay,
Okay.
fine.
Also, we need to spend some time. We need to spend some time at the internal os. Let the water go inside the uterine cavity and it will open up or loosen up the internal os. Once the fluid goes inside the uterine cavity with pressure, it loosen up the internal os and you can actually negotiate. If you're using Bitoki type of sheath with 2.9 millimeter scope, you can remove the outer sheath and reduce the diameter. That will again help you to negotiate the internal os.
Yeah. So even injection of lignocaine at the level of the cervix, that also will dilate the cervix beautifully and you will be able to go in. You have highlighted that also, madam. That is also a wonderful technique. So all these paracervical blocks, all those things are found to be quite useful.
Is it lignocaine or vasopressin that is given in the
Yeah, vasopressin, lignocaine also you can inject. Sensacline, all those things can be injected. So they will help you to dilate the cervix very well. So someone has asked, even misoprostol, yes, they have mentioned whether misoprostol can be used, but the only thing is if you overdilate also it's a headache because of the, reflex. So again, tightening will be a problem. So
Misoprostol only problem is it will change your intrauterine finding. It will the endometrium become more hemorrhagic.
also, yes, that is also one problem. And if suppose cervical stenosis, we create a false passage, how do we go about it? There is a query, ma'am. Sudha, ma'am, you want to take that?
I think she's left.
Oh, she's, is it? Okay.
Yeah.
Okay, then we will address all of these. If suppose you have a cervical, in cervical stenosis, we create a false passage. How do we go about it? So the most important thing is you should identify the false passage. So if you are not able to see both the ostia and if you are seeing a myometrial fibril and few tags here and there, then definitely you know you are in the false passage. First thing is just pull your telescope out and come to the internal os and realign yourself and try looking for both the ostia. Unless and until you see the ostia, you should not venture into doing any kind of a procedure. So moment you see the internal os, I mean the osteas, then you know that how the tags of fibers will be visualized either anterior, posterior, whichever, and this just go above that and or below it, and then you'll be able to continue with your procedures. Then use of paracervical block also answered. What is the optimum pressure to be kept when hysteroscope is not available? Hysteromat is not available. So when you don't have a hysteromat, you will not be able to measure the pressure at all, right?
Yeah.
So that is very dangerous. Please don't venture into all that especially when you have a tight stenosis.
Ma'am, there are also questions in the Q&A part section, and one of them is if we are using resectoscope near cervix, do such patients need a cervical encirclage or not?
Okay, so dissectoscope near the see sometimes we just make a small nick with the Collins knife or a
Right.
and then you try to get we are not going to over dilate or overcut. That should not be done. Okay, so what is required, that amount of dilatation we can do and go inside. I don't think so you need to do a cervical circlage for such patients.
Even I feel unless you have resected a lot of the internal os fibers that you can easily identify upon going back in. And somebody has also asked about the use of vasopressin intracervical to elaborate a little bit how to use it and where exactly to give the
Actually, the
vasopressin.
video has already been shown, so I think.
Yeah.
Well, I think that was pretty much clear.
Yeah.
So just 1 ml of vasopressin, 0.05 milliunits is what is to be administered. You can inject it at 3 o'clock and 9 o'clock position, and just similarly, you can inject sensocaine, lignocaine, and all those things. So just wait for some time, and you can see the cervix nicely dilating up. In fact, I also inject vasopressin inside the myometrium, submucosal myoma. When I'm doing a myomectomy, I inject it on the myoma using an infiltration needle. So that also makes the procedure very comfortable, and it will be bloodless. And of course, it also reduces the fluid absorption. So the complications of fluid overload also can be avoided.
Right.
So we have covered everything. Any other questions left? Dr. Piyush, please check.
Doesn't look like somebody has asked if anterior cervical crypt can be attempted to cut with hysteroscopic scissors. I guess obviously yes, it can. We can use either the resectoscope or the scissors. And will it increase bleeding from the site?
No, obviously, when you're using one of these, see, most of these things, why they are having stenosis is because the tissues are all getting fibrosed.
Fibrosed, yes. So the bleeding should be less.
Not be any bleeding at all. So you can
Right,
comfort.
right. We should not be worried about bleeding when we are tackling with fibrosis part.
Yes, you can use the
Right.
sharp scissors nicely and just cut it.
Yes. So I think we're done with all the questions here, ma'am. We can
Okay.
move on to the next session.
Move to the next session. So thank you so much, Sudha Madam, for a beautiful presentation, and thank you, Piyush and Dr. Anna for interacting and chairing this session.
Thank
And
you, Dr. Mala.
thanks a lot for your time. So, Dr. Piyush, can you introduce the next chairperson, please?
Yes, ma'am. The next person, can we also add the slide? Although I will introduce from my own side. So Dr. Mrugesh B. Patel is the next chairperson. He's a gem of a person. I know him personally very well. So he's the director of Mother Care Hospital, Mehsana, Gujarat. And he's also the scientific secretary of MOGSO, and he's joint organizing secretary of SOGOG 2011. He was invited as the operating faculty and still is, and he has delivered multiple lectures in national and international conferences of FOGSI, IHA, And the last part, like I said, he is a friend of all and always, and I can vouch for it that he is a gem of a person, and sir is a wonderful person to be around. He's always very helpful for the juniors. You will never even feel that you're sitting with a senior. I think I've said a lot if sir is around, and he can please
Sir,
take over.
unfortunately, Dr. Piyush, Dr. Murugesh Patel is caught with an emergency.
Okay.
There
So,
now.
No, ma'am, I'm there. I'm there. No.
okay, sir is here.
Okay,
I had talked to him. Sir was saying he'll be available. He won't be available on the video, but the audio part he will be available though. Sir,
fine.
please.
That's great. Yeah, please. So please invite the speaker, Dr. Vidya Bhatt.
Yes, good evening, everyone. And I'm going to invite Dr. Vidya Bhatt. Everyone knows she is very well and dynamic person. And she very good laparoscopic surgeon and hysteroscopic surgeon, fertility specialist, joint secretary of IAG, treasurer of IAG 2024 and 25, governing counseling member of IAG, and
Sir, enough.
think
Sir.
the list is very long, and everybody
okay,
knows
it's
he's a
okay.
dynamic and gem of person. So over
I'm
to
pretty
you.
sure the list
Yeah, ma'am.
must be longer than the whole slide, ma'am.
Yeah.
Longer than-
Over to you, ma'am.
Anyway, I think we should move on. The topic is more important. So thank you, Mala, for this opportunity. Thank you, IAG, for inviting me for this. And Piyush, thanks for the nice words. And sir, thank you so much. In spite of you being held up in some work you have joined, thank you so much for that. So my slides are visible?
Yes, ma'am. Yes, ma'am.
Yeah,
Visible, ma'am.
thank you.
You can turn
Yes.
on the slideshow and yes, right.
Yeah,
Perfect.
yeah. Can I just put this to the side? Yes. Yeah. Okay. So, perfect the slice. Yes, I believe in this. And I feel hysteroscopic myomectomy, when you say, it is an art in itself, but hysteroscopic myomectomy is a better art, I say. Uh, Fundamentally, you have to learn different techniques to do this. And when we are in a era of talking about office hysteroscopy, every office can't do a myomectomy. you have to do conventional also, depending upon the size of the myoma. So patient selection is very important. You have to abide by the classification of the myomas and, of course, the indications. Submucous symptomatic myomas, heavy menstrual bleeding, infertility, and recurrent pregnancy loss are the indications for submucous myomectomy. And the step W classification. This was described by Lasmar. And I just love this classification because size topography, that is the position extension, how much it has extended in the cavity, and then the penetration and to the wall. That is very important to know when you want to do a submucous myomectomy. So this classification tells you the grades, the scoring, and once you score it, you have to decide whether you're going to go hysteroscopically or you can't do it hysteroscopically, or you have to do it in a double setting hysteroscopically. So when you say submucous myoma, type 0, type 1, and type 2, all this everybody knows. I think I need have to go into the classification, and this is the FIGO classification. So this will tell you that what kind of myomectomy you're going to do. Are you going to use the conventional instruments? Do you want to use a resectoscope, the new intrauterine tissue retrieval system? So all this becomes a challenge, especially when you're doing this. Sometimes you may have to do a combined approach, that is one and of course followed by the other. So then evaluation of the myoma, of course, you can do office hysteroscopy, saline sonography, MRI, ultrasound, or hysteroscopy. Prior one hysteroscopy you can do. So just to evaluate how the cavity is, or somebody else would have done it and sent it to you. So this also happens in most of our settings. And the deeper the myoma, the complication rate of fluid overload. See, we are not only talking about just the myomectomy here. Whenever you do an operative hysteroscopy, the whole system is involved. So when the whole system is involved, the fluid gets into the circulation. So you should think about the fluid deficit also. So type 0, it will be less. Type 1, roughly around 1 liter. And type 2, if you are not careful, it can go up to 1.5 to 1.6 liters. So intra-op equipment, you can use the resectoscope and electrolyte-free media. If it is a bipolar, use isotonic normal saline, and then the size of the resectoscope depending upon the size of the fibroid. If you have a small one, you can do it in office. Of course, office one has to be very pro in that to do office, basically because you have to be quick. So, and not more than 1 centimeter. Not that is not described by me, but Dr. Stefano Bitucchi himself, he says not more than 1 centimeter for office. But when you have larger fibroids, 1 centimeter fibroids, rarely you'll get. But when you have larger fibroids, you have to go through the conventional methods. So the pre-op, whatever you have to do is depending upon your aim has to be removing of the myoma in toto. That is your aim, and how you're going to do, how you're going to plan, whether you want to give a GnRH prior, everything depends upon the size, type, and the position of the myoma. So pre-op evaluating, of course, transvaginal scan, if you're a good sonologist, your own transvaginal scan is going to give you a lot of information. And sometimes we can do an intra-op one also. An ultrasound machine can be in your OT just to know the extent or how much you have removed. So ultrasound has to be a part of your operative system. Then the surgical technique, how you have to do, you have to survey the endometrial cavity, resect the cavitary portion. Do not resect too much into a hole like thin. Try to remove the capsule or make a cut on the capsule. Remove the chips whenever needed so that you've got good visualization. And when it gets deeper into the myometrium, think about the fluid deficit and identify the pseudocapsule. If possible, desiccate the bleeders and then change the pressures when you want the myoma to dip into the uterine cavity. So the different techniques which we have been using is resectoscope, then cutting the base of the myoma if it is a type 0 one, vaporization, if it is a very small one, laser also, very small one, then office hysteroscopic myomectomy, I've told you when, and sometimes if it is a very big one, you may have to do it in two procedures, or if the person is not very well versed, it is always better to go into procedures. And of course, the intrauterine morcellators. So when you have the resectoscope, the electrodes, you can either use monopolar or bipolar. I call myself senior because I'm doing this for the past 20, 22 years. So I still have my monopolar resectoscope. Whenever it is a big myoma, I switch on to the monopolar. Let me be very frank with you. Bipolar also I have, but depends upon the size of the myoma. And you have to be very quick when you're using monopolar. Then, of course, the roller ball, vaporizing electrodes if necessary. Then, of course, a spring ball or a twizzle to make an incision. This is the difference between monopolar and bipolar. I will not go into it. A Versa point, resectoscope, Collins knife, and vaporization electrodes are a part of this bipolar family. But this is one of my old videos. Whenever you have a bipolar, this was the first bipolar resectoscope which the Ethicon company introduced, and it was not very sturdy, but it was good enough to do, and the loop was very small. So we would get small bites, and it took a long time. And we did not know the newer techniques. I'll show you initially how we did. We did like this, and we took a long time. We did not think about the endometrium. But now things have changed in the past 20, 25 years, that we have a specific way of doing it, which can restore the endometrium, remove the myoma, and the patient also will be very comfortable. And we go on to this Maison's mechanical loop. I don't have a video of this, but this was used before, and I've heard of people using this just to elevate the myoma from its base. And this has to be very robust, and people have used this and they have elevated the myoma. Then, of course, using a scissor. If you have a myoma and if you don't have a resectoscope, you can try with scissors. Go to the base, cut it. And this is one of my old videos where I did not use vasopressin, but now I inject vasopressin. Things are faster, the vision is clear, and the resection is complete and the fluid overload is minimal. So this is going to the base. The basic disadvantage here is moment a blood vessel is cut, it starts spurting and you'll get a red flag. So you have to be very, very careful when using the scissors, which we did initially. So then, of course, the newer instruments which have come are the hysteroscopic morcellators and, of course, the laser. The laser is not as good because the electrode is very small and it will vaporize, like this is a Versa point. It will vaporize the myoma, which is very small. So it may not be very promising, or it will cut the pedicle. That's all. You can leave the myoma if it is a small one, but I don't leave it. I remove it. But there are papers which say that you leave the myoma, small myomas inside, it'll degenerate and come out. And of course, the parts of the resectoscope, this is something as an endoscopic surgeon, hysteroscopic surgeon, you should know this skill, because though there is intrauterine tissue retrieval system, the resectoscope goes to angles, deeper angles, and removes myoma from all over the uterine cavity. So you have the working element, you have the telescope, the electrode, could be monopolar or bipolar, inner sheath, outer sheath, and different sizes. Now you get those princess, the sleek and the beautiful resectoscopes. So that is also that also is used in your routine infertility practice. This is our own article which we have published in the Trocar journal on resectoscopes and the comprehensive review on that and the use of the resectoscope. Then this is one of the myomas. The patient had a repeated implantation failure, and they told me, why will this myoma cause a problem? But the moment you put in your hysteroscope, look at that inflammation there. How do you expect the woman to conceive with inflammation at the myoma site? And you can also see that there is a mirror image of inflammation. And there is a lot of the uterine factors which will not play for implantation. So here we have injected vasopressin. This was almost grade 1 to grade 2 and made an incision. we have to restore the endometrium. We should not damage the endometrium. I'm using a monopolar loop here, and you can you can see me making a cut on the myometrium, endometrial surface, and then the cut is made a little deeper just to shell out the myoma. And once you make an enough cut which can accommodate that myoma, just shell it out. And once you shell it out, you have the whole myoma inside the uterine cavity. And all you have to do it, just remove it with the resectoscope if possible, or you don't want to use the resectoscope. You feel you have caused enough of damage to the endometrium, which is just a linear cut. Use the intrauterine tissue retrieval system. A grade 1 to 2 myoma becomes grade 0, and then you can remove it with the intrauterine tissue retrieval system like this. And the patient conceived once we did the embryo transfer. Of course, then the slicing method to the topic. You can inject vasopressin. This, as Dr. Mala said, this is a beautiful technique, 10 to 15 ml. You use about 5 to 10 ml sometimes, or 5 to 8 ml. I use the OM pickup needle because of our IVF centers. We use that because it will easily go, it will reach the myoma. And then once you inject that, there is hardly any bleeding, and slice it. Once you slice it, what happens? The myoma is now in bits, and it is very easy to remove with your resectoscope, or you can even use, it is faster, and you can use the intrauterine tissue retrieval system, which will just remove the myoma. Because it is in bits, you can negotiate and dip into the myoma faster and remove it. So this is something which will really help using all the three instruments. Then this was just referred to me yesterday. I literally ate my fellow's head and then made her do it. Made her edit this video. The myoma is through and through the cavity. It is sitting through and through the cavity, and the very look of it, initially they thought it was a polyp, and then they tried to remove it. But see, it is not a polyp. When I injected the vasopressin, I could feel that thick tissue of the myoma. So made multiple cuts on the myoma, slicing from one end to the other end. The upper part was almost up to the fundus. So I had to make a linear cut and look at that linear cut which I've made, and multiple cuts, then use the resectoscope. And after using the resectoscope, when I debulk the myoma, then I use the intrauterine tissue retrieval system. So this was very comfortable, and my anesthetist was very happy because, see, you have your anesthetist who will look at the fluid management system, and one nurse will be looking at how much fluid has gone in and gone out. So when you finish it fast, they are also very happy. Hardly 2.5 liters have gone in, and there is already 2 liters in the bucket. The deficit is less. So the surgery is also fine, and then the patient goes home the same evening. So we have published this article with the OM pickup needle, hysteroscopic myomectomy. This has been very good, and I'm practicing this since many years. Then, of course, sometimes you have double trouble. Myoma with the septum. This repeated hysteroscopies and DNCs this patient has had, and they have gone into the other cavity and curated the retained products of conception. They thought it was retained products of conception, and the fibroid has undergone degeneration. And beta HCGs were negative. Then when she came to me, I knew there was a septum, and the other cavity was full of that degenerated fibroid. Now, what do you do first? That is the question everybody asks. So just remove the septum. Once you remove the septum, what happens? The cavity is well distended, and then you have the myoma at your site, and then you do intrauterine, because this was a grade 0 myoma, and resecting it would be a challenge. Basically because it was a degenerated myoma, and getting bits was really difficult. So we used the intrauterine tissue retrieval system. So the whole myoma was out, and now she has conceived. She has 2 kids now. So then opening up the capsule, this is something which Professor Lasmar described. He said, you just open up the capsule and leave. The myoma will dip into the cavity. Well, if it is a deeper, this was a large myoma. So what we did, we opened the cavity I mean, we opened the capsule, and after opening the capsule, of course, injection of vasopressin goes without saying, because that is now the most important step. And then once you open the capsule, see, we have opened the capsule here, made a big incision, and then the endometrium just separates because the myoma dips in. When you decrease the pressure, the myoma dips in, and then you can remove the myoma. A grade 2 becomes grade 1, and grade 0 it will come to. So you resect the myoma. This was a large myoma, but it could be done successfully because of these small tricks which you follow. And the beauty is the endometrium, hardly there is any damage to the endometrium. The myoma is completely resected, and just see, you can see the cavity there, but the endometrium remains untouched. So this is something which we have to follow. And this was a bomb for me. 13 myomas I removed, and the radiologist who did a scan said, "Are you crazy, ma'am? You're going to remove those myomas hysteroscopically." I said, "Let me try. I want the patient to conceive." So we removed these 13 myomas, and I thought she would have gone in for Asherman's. I told her, "We'll do a relook, and then maybe we will do IVF." Patient didn't come. She said, "At present, I don't have money for IVF." And then she came back later saying that she hasn't got her periods. Whatever little scanty periods I would get, I'm not getting now. Then I was a little worried where I've caused the whole cavity obliteration. But when I did a scan, I could see a nice intrauterine pregnancy, which then the patient was blessed with the boy baby. And I removed 19 myomas at the time of section. So you can see the beautiful uterus, the beautiful baby, and the beautiful surgeon. So this is our case which we published. And of course, the morcellators. Thinking about the morcellators, you should not call it morcellator, but it is an intrauterine tissue retrieval system. The advantage is learning curve is very less. It eliminates all the bits. You can use normal saline, and it is not electrical energy. It is mechanical energy. Disadvantage, you can't go for deeper myomas. It has two blades, the rotatory and the reciprocating blade. This is by the TrueClear, and I use the TrueClear. You have the smaller ones also. So this is a intrauterine grade 0 myoma, which we use the TrueClear, and of course injected vasopressin. And you can see there is no bleeding. Only if you inject vasopressin, there won't be bleeding, not like the resectoscope, because if you have a bleeding in between, then you will get a red flag and you won't be able to see anything. So the advantage is the very next cycle you can do IUI and IVF, no energy source, no endometrial damage, and no intrauterine adhesions. So it's a safe, efficient, effective, and clear. And this is our own publication, which we had published saying that it was faster. And this is the TrueClear, which we bought. There is another MyoSure, then Symphon. All these are available. Then a meta-analysis came saying that it is faster and it can be used. And when you compare the resectoscope and the morcellator, though it is faster and tissues can be removed, you can't use for myomas which are deeper, and it's definitely expensive. Then there's something like this. Don't even attempt this. They say no. Sochna bhi mat. Never try this hysteroscopically. When you have a fibroid sitting in the cervix, and it is a temptation, to take your resectoscope and start resecting. No. Look at the size of the fibroid, see the lateral extent. And when we saw the lateral extent, sometimes it can be misleading. And the whole thing was inside like this. It was a cervical big fibroid. So we had to do laparoscopy. So never even think about this. And then there is one case where you have in the isthmosil myoma setting. Don't even try this, because it is better you go laparoscopically and then remove this fibroid. So it is not always hysteroscopy. You should be equipped with laparoscopy also. So the deeper the myoma, the success rate is less, whereas type 0 removal is good. This is depending upon everybody's skill. A skilled person may do it very comfortably. And if you use these tricks, definitely you can use it better. And of course, intrauterine pressure has to be there. And then you avoid venous sinuses, resect intracavitary portion first. cauterize whenever necessary. Then, of course, you have the mechanical tissue removal system, which is available. These are the different ones. You can buy those. Resectoscopy, pros and cons, chip management, air bubbles, and learning curve is the cons for a sectoscopy, and it is pro for the intrauterine tissue retrieval system. But angled hysteroscopy, the difficult ones, and this is not an alternative for resectoscopy. So please learn your resectoscopy and always keep in mind the fluid management system. Follow the AGL guidelines so that you don't land with disasters. So whenever there is a complication, cauterize the blood vessels, put intrauterine balloon and intrauterine soaked gauze with pitricin, embolization. All this I've not done. I've just done intrauterine packing, hysterectomy, rollerball ablation. Not always it is helpful, but sometimes. You may see a red flag and then you have to increase pressure. So it may not be helpful always. So bleeding prevention, you have to know the technique. Vaporization, of course, if it's a small fibroid, the pseudo capsule, shaving, cold loop, all this has to be kept in mind. And ultrasound, you should wheel it into your OT whenever necessary. So with the advent of new instruments in hysteroscopy, the procedures which can be done through hysteroscopy is on the rise. It is mandatory for us to improve our skills and also invest on the equipment whenever necessary. Simply don't invest it only whenever necessary, only when you know you can have enough material for that equipment, buy it. Thank you very much for your kind attention.
So that was a beautiful presentation, lovely, beautiful videos, all different kinds of myomas you had and different techniques. It's simply great.
Thank you, Mala. Thank you so much.
Great to
So you
watch.
should have a friend to be at your chair, your chair. So she'll praise you.
No, no, no. I truly mean every word of what I said.
Thank you so much.
It was
Thank
really fantastic because the moment I knew myomectomy, you only came in mind in hysteroscopy. It is an art, like how lap suturing is an art, like hysteroscopic myomectomy is also an art. Of course, all the different techniques and modalities you have showed beautifully. But only thing is, we need to know when to use where so that like we'll be able to use it to its optimum and also our myometrial boundaries. So you very clearly showed how the cervical fibroid should not be tackled hysteroscopically. That is very important. You should know when to stop. And at the same time, you also removed a 13 myomas hysteroscopically and you got away with that without having any additions. And the patient also was approved to it by getting pregnant. So in such a scenario, I would prefer to open up the cavity and remove all of that because the fear of constant damage to the basalis is always there. But then not every patient is lucky, but that was a very beautiful demonstration of this. Most important is like where you are able to finish it in a single sitting.
Yeah, all those 13 fibroids I removed. It was like dipping one after the another. And then it was some 26 myomas. It was completely like a fibromatosis. And my radiologist told me, "You're crazy, ma'am. What are you doing? Just, I don't think she'll conceive." But when I went in, it was tempting. And then there was no fluid overload because it was quick.
Yeah.
So
So
I was lucky, patient was lucky. And then she came back again for the second child, but she didn't conceive.
yeah, good, good, good. That was a very nice one. Of course, the True Clear also is a very beautiful instrument. So only thing is, like as you said, it is okay only for small myomas and also the superficial type 0 and 1 myomas. I mean, off the audio. Okay, so sorry. So it is again a very beautiful instrument for us to perform myomectomy, and of course, in that case, vasopressin is very, very effective when we are
Yes,
using
yeah.
that here because it makes the myoma also very soft. When you inject vasopressin, so
Yeah,
as a result,
yes.
that resection becomes very easy when you use TrueClear. So different kind of thing, and also how a pseudo capsule is very important, not only just with other types of myomas, even in submucosal myoma. Now the current concept is how we need to retain the pseudo capsule for better healing of the endometrium. So I think in that way your slicing technique was very good. Where how you make a nick on the on the capsule, and you are inoculating the myoma and leaving behind the capsule. That's again.
Just like laparoscopy, ma'am. Exactly like laparoscopy.
So it is a very nice technique and very beautiful to watch all the lovely surgeries, Dr. Vidya. So are there any questions, Dr.
Yes, ma'am. There is a
Yeah, a lot of
question
questions.
in the Q&A section by Dr. Anupama. She has asked to inject vasopressin using OPU needle, how to detect blood on aspiration as the needle tip is not transparent.
Yeah, needle tip is not transparent. You have to give a long pull. Now the stem cell therapy needles are available, which is transparent. But see, this is a very small needle.
Yeah.
So you inspect the area where there is no vessel. Usually you will see vessels. So inspect the area where don't hit into that vessel. Just go into the fibrous tissue of the
Right.
myoma, and once you get into that fibrous myoma tissue, because you'll feel it. So then you inject vasopressin, and you're not injecting much here, 5 to 8 ml, so it
Yeah,
doesn't really.
it should not cause that much of a
Yeah,
problem.
yeah,
Moreover, since we are not going into the myometrium, we are
yeah.
less likely to encounter more
Yes,
vessels.
yes.
Anyway, most of these surgeries are associated with laparoscopy. One can inject laparoscopic vasopressin. What I routinely do for a bigger submucous
That can
fibroid.
also be done, sir. Yes.
So
Yeah.
you just inject in the uterine muscle and it will take care of everything.
And then we proceed
Yes.
hysteroscopically.
Yes.
Quite easy, quite simple.
Yeah, so you can also inject some on the cervix also.
Yeah. Yes.
Definitely.
Okay.
I think there are no more questions from this chat. Yes.
Thank you so much, Dr. Vidya. So I think it was a great presentation, and thanks for your time as well. So we'll move on to the next speaker. So may I request Dr. Kajal to introduce our chairperson, and then Dr. Yeah, please take over, Dr. Kajal.
Yes, to Dr. Vidya, it's been a while, but this is nice. I would like to call upon the next moderator, Dr. Egbert Saldana, sir. He's an absolutely amazing obstetrician and gynecologist. He's a laparoscopic surgeon at Sriji Hospital, Ghatkopar, and Zen Hospital, Chembur. And he is an honorary at Shatabdi Hospital, Govandi. He's also the president of IMA, Chembur. So over to you to introduce the next speaker.
Thank you, Kajal, and thank you, Dr. Mala, for giving me, and IAG for giving me the opportunity to chair this session. And it gives me great pleasure to, introduce the next speaker, Dr. Nitin. I think Nitin is the president of the Association of Fellow Gynecologists, a very active member, managing committee member of IAG. Of course, we know him all as a financial wizard, and of course, a laparoscopic and a hysteroscopic surgeon par excellence, and a great human being. And of course, he has, done a lot of other feats, like the biggest, largest ovarian cyst. He has done he's very avid, fond of trekking. So a lot more that I can go on and on and on. But I think it's really a pleasure to have Nitin, and always a pleasure to spend time with him. Over to you, Nitin.
Thank you, Egbert sir, for a kind words. And let me share my slides. Today my talk is on the energy sources and rare cases in... is my slide visible?
Yeah, yeah.
Yes.
I think previous two speaker has made my job very, very easy. So advancement, hysteroscopic technique, everything has been taken very well by both the speakers. So slicing technique, of course, everybody has demonstrated very nicely. So what I will suggest is by doing a diagonal approach, you cut diagonally, don't cut vertically. What we are used to do is get a vertical slice. You go diagonally and take a bigger chip. That will save your time, and you will get a bigger bite also and longer strips also, and that will save your time and the fluid overload in this. Okay, what madam has not shown is a resection master, but I think there is not a much popular one because the chip get accumulated inside the uterine cavity. This is attached with the suction machine. So once the chip get formed and your loop comes inside the resectoscope, the chip get aspirated automatically because of the suction machine. But because of the cost factor, this machine is not so popularized. Loops and everything madam has shown very nicely. This was the laser fulguration or evaporation of the fibroid. This was missed, so I thought I will cover this also. So smaller fibroid, which is 2 centimeter or less, this can be done by using a ND-YAG laser. You just pop inside the fibroid. The only disadvantage is there is no tissue which will be available for histopath because this goes, everything gets evaporated. Morcellation, madam spoke very well on morcellation, so I will not go into that detail. Opium technique was standardized by Professor Bitoki, where he showed that G2 fibroid or G1 fibroid, you just take a peripheral incision in the office setting, send the patient back, and after 1 or 2 cycles, you will see that fibroid has become grade 0, and then you can finish in the office setting. So that was the opium technique. The detail, what we can do. So advantage is bipolar diathermy. I am sure everybody has shifted from monopolar to bipolar. Nobody is using monopolar except some urologists because monopolar requires use of glycine, which has a various side effects. So this is a very nice video of a bipolar saline needle. So you can just slice the polyp or a fibroid into two and then chop it up from the base. And this is very, very easy. Madam has shown with the use of the Colvin's knife, but one can use this bipolar saline needle which is available, and that also a 5 French goes through the hysteroscopic side channel and job can be done very nicely. So this is just a slicing technique. The same thing can be done with the help of the scissor also. This was a postmenopausal woman where you could not find the cervix, and you see we went inside with a vaginoscopic approach where cervix was flushed with the vagina, and you can see this mushroom shaped elongated polyp. So with the help of the scissor, you can just cut everything into small, small pieces before detaching it. Because once you detach, and because of the eddy current of the fluid, the polyp will keep rotating and it will be difficult to grasp. So don't detach, just make a small, small pieces beforehand and then finally chop it off from the base. So this is how you can, plan your surgery. Hysteroscopy is an art, as rightly said by the previous speaker, so you have to follow that small, small steps because your field of play is very small, hardly 5 centimeter uterine size inside the cavity. So you cannot be very aggressive. So this was the video. Now coming to something new, microwave ablation in the use of hysteroscopy. Now everybody, we have talked a lot about microwave ablation. So it's nothing but a frictional heat which causes coagulative necrosis of the tissue and finally causes absorption, lysis and absorption of the cell and prevent the proliferation. Especially microwave ablation we have started using nowadays in the adenomyosis, uterine fibroid, cervical erosion, maybe fetal reduction, post-MTP, AV malformation, and scar endometriosis. Okay, so this is the echo machine which is available. These are the probes or antenna, what we call. Okay, so benefits are it's a uterine preserving surgery, and if the patient doesn't want to remove uterus, definitely this is one of the newer modality one can use. What we have done, this is this was the live workshop what we conducted last week in Shatabdi. We demonstrated the use of microwave ablation in a adenomyotic uterus where family was completed. We are still skeptical to use in the patient with the infertility because we don't want to damage the endometrium. Because with thermal energy, if the endometrium gets damaged, then it will be very difficult for patient to become pregnant. So this was an adenomyoma case. And this was another case what we demonstrated is everybody knows about therma-choice balloon ablation. You used to put the balloon and the hot water goes inside and there was an endometrial damage, but the corner region was left behind. So this is an angulated probe. Microwave ablation angulated probe. You can see the tip is angulated. Under abdominal probe, you just put your probe inside the uterine cavity and you can see that clouding. So this is the microwave ablation of the endometrium where family is completed for the abnormal uterine bleeding. Okay. And if there is suppose an adenomyoma component, what you can do, you can use a final probe or finer probe or a antenna and you can puncture the endometrium and you can ablate the adenomyoma also. This is an immediate post-operative picture of the microwave ablation. You can see the entire endometrium is being burned. Because of the angulation, you can reach the cornu also. and the zone of ablation can be appreciated on the sonography while doing the procedure. So this is something new we can think about when the patient want to preserve the uterus rather than going for therma choice or marina. If that has failed, we can try microwave ablation. So my hysteroscope is my stethoscope. Every gynecologist should learn how to do hysteroscopy, because you can see the cervix is ready to, when you do vaginoscopy, the fluid, it like, actually speaking with you, the cervix opens, close nicely. So this was the spot diagnosis, what madam shows initially, the crisscross appearance of the fibros, and there's a false passage. Okay. So false passage, how to diagnose, Sudha madam nicely demonstrated that part. So you just depress the hysteroscope and you will see the opening above that. Okay. Because the uterus is usually antevated. What we do is we pass the cannula or a dilator perpendicular straight, so we will make a perforation in the posterior wall of the uterus ideally. So you just come out, depress the hysteroscope, and you will see the internal loss on the top. This is how you should negotiate. So how to overcome difficult entry, madam has shown very nicely. I would just like to show the video of power of distension medium. You just give some time at the internal loss. Let the water seep inside the uterine cavity. Once the uterine cavity is distended, internal loss automatically get open up. You can see the internal loss is opening nicely. So you just need to give some time at the internal loss. Wait for some time. Let the fluid go inside the uterine cavity with the pressure, and it will open up. So you don't have to do any jugularly, any dilatation, and you will walk inside the uterine cavity. Polypectomy, we have seen using the both. So how to start hysteroscopy? There are many youngsters who want to start hysteroscopy, but they fumble. Buy some Simla Mirchi from the market, and you can use you puncture that Simla Mirchi, and there are a lot of polyp inside. You can use Caesar and grasper, and you can start learning, how to just tackle the polyp and pick it up like a foreign body removal. After cutting the polyp, you can remove with the help of the grasper, and this will definitely improve your head-eye coordination during the hysteroscopy. This is a very interesting case of a footprint lesion. You can see the polyp on the anterior lip of the anterior uterine wall. And when we collapse, you can see that inflammation is on the posterior wall. So that is a footprint lesion. We have published this case, and that is an inflammation on the posterior wall of the uterus due to the polyp on the anterior wall. So you can see how this contact lesion, this is also published by Dr. Alka Kumar as a contact lesion inside the uterine cavity, and we have published as a footprint lesion. So you can see this contact lesion causes inflammation, intense inflammation and indentation in the opposite uterine wall, causing inflammation. So this case was published in ICology journal, the footprint lesion, a mirror image of the endometrial polyp. This is a very interesting case of a secondary infertility. All the findings were normal. And when we were doing hysteroscopy, everything looks normal. We went up, started with dye testing, but dye didn't came. So we just went inside for the cannulation, and then we could see the bilateral corneal polyp which are popping out. See? Okay, so these small polyps were blocking the ostia, bilateral corneal polyp blocking the ostia, and you just pluck it off this, and the patient become pregnant in 2 to 3 cycles. So this is a small. You can see the cornu polyp here also. So you just reduce the pressure. Once you reduce the pressure, polyp will come inside the uterine cavity. You hold with the grasper and just remove it. This was also a very interesting case of the cervical polyp, huge 6 centimeter protruding from the cervical external os into the vagina. You can see this is a vaginoscopic picture, a huge fibroid polyp. And you can see that the cervix is dilated. The polyp is coming out of that. Now, if you avulse and remove this, the base will be remain inside. So we do a hysteroscopy, go inside and find out where the base is. And you can see the base is quite above into the anterior abdominal wall. It's coming from, coming from the anterior uterine wall. You can see this, it's coming from the anterior uterine wall. So with the help of the resectoscope, you go to the base and remove the base. So for the complete excision of the polyp. So just make a few nick with the resectoscope in the anterior uterine wall, and you remove that from the base, and the entire fibroid polyp will slide out from the vagina. So just by giving 3 to 4 cut, you can see there is a feeder vessel. Always check for this feeder vessel, and you can just put your loop there and give some coax current, and it will stop. One should not be worried about the bleeder in the hysteroscopy, because once you remove your resectoscope and the fluid is gone, the two wall oppose each other and the bleeding will stop automatically. So don't worry about the much bleeding in the hysteroscopy. It will be taken care. Just give a uterine massage or pack and it will take care. This was again a very interesting case of the polyp coming from the uterus into the vagina. The sonography was showing 9 centimeter polyp, but I was doubtful 9 centimeter polyp will never stay if it is not a fibroid. So we did a MRI, and to our surprise, we found that it was an uterine inversion with the. So this was the MRI finding where the fibroid, submucous fibroid, was pulling, dragging the fundus of the uterus, and there was a uterine inversion. So this was the laparoscopic picture. You can see everything has gone inside. So we started with the bilateral uterine artery ligation. We just open up the space. We didn't ligate or cauterize because in case there was a bleeding, we need to cauterize. So it's like a Halton procedure where the posterior uterine wall was cut open and gently we pull back the uterus into normal position. You can see that fibroid, which was dragging the entire fundus down. So it is a chronic inversion of the uterus, and you can see the huge fibroid. Okay, so this fibroid was seen from below. If I would have started my surgery from below, I would have made rent and we would have missed this. So fibroid was removed, and then the posterior uterine wall was sutured using the BAP suture, and the uterus was restored to normal anatomy. So this is the final picture. So this was also published in Indian Journal of Gynec Endoscopic Society, IAG journal. This was a case of primary infertility. A lot of time we see these micropolyps which are there in the uterine cavity. So these micropolyps are suggestive of endometritis, some sort of infection. And so when we did laparoscopy, we could find there is a PID. So you can see a lot of micropolyps inside. So whenever you do hysteroscopy, always go closer to the endometrium and try to look for whether there is an infection or micropolyp. You can see there was a Fish-Curtis syndrome. So this patient require antibiotic therapy. This was a second case of a secondary infertility. A USG was showing an echogenic focus inside the endometrium. And what are the differential diagnoses of echogenic focus in the endometrium? The four common thing is osseous metaplasia of the endometrium, remnant of fetal bone, embedded or broken copper T, and foreign body. So this was an interesting case of osseous metaplasia of the endometrium. There was a history of late trimester abortion, and there was a late trimester abortion, and so we went inside with the help of the Caesar. There was some addition. You can see the sheath-like bony material inside the uterine cavity. This does not resemble to any human fetal bone. So this was nothing but an osseous metaplasia of the endometrium, where the endometrial insult start producing the bone-like structure in a sheath form. So this we published in the journal also, and I think till date we have done almost 13 to 14 cases of the osseous metaplasia of the endometrium. So this is a classic picture of the osseous metaplasia. You need to remove all the spicules with the help of the grasper and try to remove curate from the basal layer of the endometrium. And you just poke with the grasper or something. If you are finding any hard thing, you need to remove that. Okay, so that is very important. Otherwise, the recurrence rate will be high. So this was published on the cover page of Jogi and International Journal. This was also a case of a late trimester MTP. Here you can see a combination of the fetal bone as well as osseous metaplasia. So this video, this was the USG finding where the echogenic focus is there. This is 3D USG. And once we went with the hysteroscope inside, you can see the entire uterine cavity is filled with the multiple fetal bone as well as osseous metaplasia. So you can see here, this is the long bone, clavicle, and many things which will resemble the human fetal bone. Okay. So, and it was a combination of osseous metaplasia with the fetal bone. This was a case of broken copper T. You can see the multi-load one arm is embedded inside the uterine myometrium. We tried to pull it with the grasper. It was very difficult. It didn't came out. So we thought of perforation. We put in a scope from the top and look whether there is any perforation or adhesion. But luckily there was nothing. So we just again went back, did some adhesiolysis using the Caesar, and then released the entire adhesion around the broken arm. And then you can see that second arm was also lying in the myometrium. So we cut with the Caesar, and then both the arms were removed successfully. So probably while pulling out, the vertical arm has come out, but the both arms were embedded inside the myometrium. So with the help of the combination of grasper and Caesar, you can complete the procedure. This was also an interesting case of copperty in a false passage. So you can see this is a false passage. Copperty was gone into the false passage, and you can see the uterine cavity is normal on the right side. Now this is a normal uterine cavity, and you can see that copperty has gone and was inserted into the false passage. This was again an interesting case of pyometra with a copperty. You can see the pus is coming out from the patient came with a purulent discharge. So this is sometime a complication of the copperty where the ascending infection can lead to the pyometra. Patient was known case of diabetes uncontrolled, and that's why she had some collection and foul smelling discharge. You can see the pus is draining from that. So we have to remove the copperty. We send this for the culture and sensitivity and higher antibiotic. Patient was shifted on. This is again a copperty embedded in the anterior myometrium. So you can see it's completely embedded in the anterior wall. So with the combination of adhesiolysis, with the help of the grasper and Caesar, we could achieve complete excision. This was something we have seen only in the family planning department of our college. But lucky to got this one on the case. She was an 82-year-old patient, came with the leukorrhea, and we just put the scope inside and we found this. Okay, so we have never seen that. It was only in family planning tray we could see that. It's nothing but the Lippis loop. So with the help of the grasper, we removed. And so it was a Lippis loop, and this was the X-ray finding. We published this case, Lost and Found Department of Family Planning. This was an interesting case. I was called in an emergency that a consultant was doing MTP, and the tip of the MVA syringe got broken inside the uterine cavity. So we tried removing with the hysteroscopic grasper, but it was not possible because it was 5 French and it was quite thick. So it was not holding it properly. So we struggled for some time, and then, it clicked that let's use laparoscopic tenaculum by the side of the hysteroscope. And we were able to manage that, and we removed that. So this is the laparoscopic tenaculum coming from the side of the hysteroscope, and we could able to hold that plastic cannula and remove it. Then after 6 months, I was called for this. This is a metal tip cannula, broken inside. So the moral of the story is always inspect your equipment before using, don't use until it breaks down. So this was a metal tip cannula with broken inside the uterine cavity. So straightforward, I went with the laparoscopic tenaculum by the side of the hysteroscope and removed it. This was also published on cover page. So we have developed this technique of use of laparoscopic tenaculum by the side of the hysteroscope, where we don't have these sturdy loops, what cold loops madam has shown in previous video for the myomectomy. What we do is we remove this fibroid 30-40% using bipolar saline resectoscope. And once we approach near the endometrium, you replace the resectoscope with the laparoscopic tenaculum by the side of the hysteroscope, and you can actually pull out the entire fibroid from the capsule. Can you see that? So this is how the position is. You introduce from the side, and you can see the entire fibroid will come out from the capsule. So this is how you preserve the pseudocapsule also. And this remaining part, and you can just go and check again that everything is normal. We will not actually appreciate where was the myoma bed was. It's so easy, nice. So this technique also we published, and it was in the one of the chapter by Dr. Sushma Deshmukh. This was an interesting case of a vaginal septum. We use a bipolar saline resectoscope for cutting it because patient was having a severe dyspareunia. So what we did is we cut the vaginal, so you can see the broad fundus. So it was a complete uterocervico-vaginal septum. So with the help of the bipolar saline resectoscope, We cut the vaginal septum up to the cervical region, and then we put the Foley's on the one side of the septum. So from one of the cervix, we put the pediatric Foley's, inflate it so that the septum get intrauterine part of the septum get distended. Put the resectoscope from the opposite cervix and try to cut the entire septum. So this is how vaginal septum is taken care. And then this is the intrauterine part of the septum. After putting the Foley's, you can see we are using the bipolar saline resectoscope. And once you see the Foley's in the opposite cavity, that means you have reached on the opposite side. You can see that Foley's, pediatric Foley's lying in the opposite side, and you just unify the cavity. So this is how you insert the Foley's to prevent the intrauterine adhesion, because nowadays people do a lot of intrauterine surgery. So you just inflate, cut the of the balloon, tip beyond the balloon you can cut, and then this is how you place. You again aspirate, deflate the balloon, and you can insert that inside the uterine cavity. So this is just for demonstration purpose how the balloon fits after the adhesiolysis or the septum resection. Okay, you can just inflate and place the balloon inside. This was a very interesting case of the isthmosil. Everybody knows now isthmosil is so common. People have seen left center, but this was presented with the anterior cervical fibroid, 3 centimeter. Okay, so when I started my hysteroscopy, it was very suspicious. Okay, there's something fishy. So you can see this was the picture. Okay, now I started my hysteroscopy and I could see something coming from the anterior cervical crypt. Okay, you can see the blood coming, and now this I'm going further, and then the internal os is coming. Okay, so the blood is coming anteriorly. Now this is the internal os. Okay, I again came back and reduced the pressure. I can see the blood coming from the anterior cervical crypts. Okay, so this all is collected blood which is coming. So I was, what is happening? Then I went inside and I could see that there was a blood in the uterine cavity also. Okay. So this is right ostia, this is left ostia. I again came back, evaluated what is it. Again this, so I thought of entering through this opening, and that again led me to the uterine cavity. Okay, so what we did with the help of the resectoscope, we cut entire ridge in between. So it was not a cervical fibroid or something, it was just an isthmosil. So this was the opening in the anterior lip and the cervical canal. So in between, we cut with the scissor, and finally with the help of the resectoscope, we removed the entire ridge. Since patient was not desirous of future fertility, we didn't repair. Madam, I'll call you in 5 minutes. Okay, so with the help of the resectoscope, we tried to remove all the ridge in between. Okay, and so this is a very old video where we used to get scissor, and you can see that scissor screw is coming out, and that screw, fallen inside the uterine cavity. So with the help of the grasper, we have removed that, but always disciplinary surgeons sound knowledge about anatomy, equipment, and do a routine inspection of your equipment and instrument. This mishap should not happen intra-op. This was again a very interesting case of a uterocutaneous fistula. Patient was having repeated menstruation through the LSCS scar side. So we did a hysteroscopy, and during hysteroscopy, you can see the fluid is coming from the LSCS scar side. Okay, so patient was having cyclical menses through the LSCS scar site. This is nothing but a uterocutaneous fistula. Okay, so we did a hysteroscopy. We tried to locate. These are both in ostia. So we came back and we could see the fistula tract inside this. So this was the fistula tract seen from the hysteroscopy. So we just passed some cannula guide wire through it. And then we put a laparoscope, and it was a tuberculosis. You can see there were a lot of tubercles which could see. So this was post LSCS. Because of tuberculosis, she developed uterocutaneous fistula. So the entire ventrofix uterus was separated. And the tract from the uterine side also was excised. And the uterus was open, the entire tract was excised, was suture back. And then the skin side fistula, we excise the entire, we open up the entire LACS side from the skin up to the sheath, and the entire part was excised. Put some momental patch so that the refistula should not occur. And patient was put on AKT, and this entire tract was excised, and she did very well. And this case was also published in journal. This is again an Ovira syndrome. Many people, just remove this obstructed rudimentary horn. But ideally, if you do MRI, you can pick up that there is an ipsilateral renal agenesis along with the hematometra, hematocolpus. But patient is having regular menses. So one need to diagnose this entity of Ovira syndrome. So there is an absent right ureter. You can see the kidney of that side is also absent. Left side, you can see ureteric peristalsis. So we went vaginoscopically, you can see a nice bulge of asymmetric vaginal septum. So with the help of the bipolar saline research, you just need to excise that vaginal septum and do a wide opening. Otherwise, there will be a stenosis and again patient will develop hematocolpus. So you excise that entire vaginal septum and entire blood will start draining out. So it's a very simple procedure. Just remove that vaginal septum, asymmetric vaginal septum, and the surgery is over. But the opening should be adequate enough so that the drainage continues. This also was published in JAMIC journal. Similar entity is a Robert uterus, where there is a single fundus. There is a single fundus, but when you do hysteroscopy, you will see only single ostia, because there is an asymmetric intrauterine septum which is causing obstruction and a hematometra, and patient will have cyclical pain. So with the help of the scissor, you just cut that asymmetric intrauterine septum and drain that collected blood, and try to unify the cavity, and that will take care of the procedure. So differentiation is very, very important with a combination of the hysteroscopy and laparoscopy. So this was also published on journal. This is the last case of the fused labia. This is the adult patient came with the fused labia, and she was just, whenever she used to, you can see the entire labia is fused. Only small opening is there from where she used to pass her urine and even menstrual blood. So it gets ballooned out during the menses. So we just passed the small hysteroscope from that opening, and we evaluated that vagina is well developed, everything is fine, there is no abnormality. So we just cut open that fused labia, and the surgery was over. So just made an incision, sutured the edges like a marsupialization with a 3-0 Vicryl, and in follow-up, everything was nice. Okay. This was also published in one of the journal. So thank you very much for this opportunity, Mala madam and Kalyan sir. Thank you. Thank you, Egbert sir, for chairing the session. Thank you, Kajal madam.
Excellent
It
presentation.
was,
I mean, what videos we really enjoyed.
Dr. Nathan, I really envy you. Where do you get all these cases from?
Sir has
All
not.
confused.
This is just a friction of it. Sir's got abundant. This is hysteroscopy. There's laparoscopy
I
and
know.
whatnot, right? Complications and that he's tackled. So he's got a plethora of cases, and these were just far and few that we saw. The best was the inversion, the uterocutaneous TB. That's quite unlikely post-cesarean section. So, wow. And you operated on a TB, like an active TB
It was
patient.
intra-op
So,
diagnosis, but we have to treat. And then
You
so we
had to
treated
operate. That's all. So the
and
tissue
we tried
quality
it,
must be,
yes. And
yeah,
immediately
tissue.
she was put on AKT after the
Correct.
histopath report. So she resolved, she was very nice. So
Correct. But the tissue quality might not be that good for
yes.
you to
Yeah.
operate upon, right? Yeah. So, but usually when you do these cases, what is your post-op management medically? In terms of when you have such aggressive intra-op diagnosis, how do you post-operatively, what kind of
In case of
management do you?
tuberculosis?
No, in case of all of the hysteroscopic procedure, minus tuberculosis.
Okay.
Tuberculosis is AKT.
Yeah.
But when you have large fibroids, polyps, do you have a particular regimen that you follow?
No, no, routine antibiotic, routine things. So don't overtreat. Now, doing nothing, it will see
Okay.
uterus collapses after removing whatever pathology. Uterus will contract. If require, you just put some cytotec or something which helps in uterine contraction. Because once the uterus contract, the bleeding is out. Bleeding will not
Taken
will
care of.
happen.
Okay.
Never. It will never happen. Today only we did very interesting case of cervical fibroid
Hmm.
just before coming here. And in MRI, it was like posterior lip used cervical fibroid. So we
Correct.
managed to do a hysteroscopy and then injected vasopressin and just cut open the capsule and enucleate the fibroid
Hmm.
and just base causalite, doing nothing and everything settled.
So it's always nothing with y'all. Yeah. So how much is the dilatation that is required for your cervical canal when you introduce a laparoscopic instrument? So you must, when we do
You need to
vaginoscopic, then
dilate till 10.
10 Hegas.
Because because initially what we used to use were these videos are with 4 mm hysteroscope. So your diameter
Correct.
is already 7 to 8. So
And
Correct.
don't you
for
lose any
putting,
fluid?
sorry?
Don't you lose any fluid,
No, no,
like
madam,
leakage
because
of fluid when
no,
you put it
because with this combination, it will
alongside?
block. And if require, my assistant will put a finger by the side of the cervix. So fluid leakage won't be there.
Mm.
Correct.
So beautiful collection. Excellent. I think your freelancing has really helped you to get all
Yeah,
Oh,
I'm sure.
massive,
That
massive
I'm sure.
volumes. True.
Okay, so even those osteous metaplasia, all those things are also very nice, beautiful. And you have managed to record all of them. So that is the best
We
thing.
record
And
all the surgery,
publish.
madam.
And
We
publish.
record all the surgeries.
Yeah, exactly.
But
Record,
and
edit,
publish.
and
And
store
publish.
is also very important, and publish. Yeah.
Publish.
That's been there are a few questions, I think. Let us
Yes,
just.
madam.
Yes.
I put it in the. He's on the cover page of all the journals.
Yeah.
So he's a cover page surgeon.
He's a celebrity. Okay, 1 minute. Let us
There
see.
is one question. How do you know that we have removed the fibroid fully when we are resecting a submucous fibroid?
See, whenever you see the consistency of the fibroid and the pink muscle fibers, whenever the fibroid will end, you will start seeing the pseudocapsule. That fibroid is popping out, getting separated from the myometrial fibers. So at
Hmm.
that time, you will start appearing a pinkish myometrial fibril will be visible. At that
Hmm.
time, you have to stop.
Hmm.
Okay.
Yeah.
So it's quite obvious. If you see
Yeah.
complete excision of the video, you will realize that where the fibroid is ending and where the myometrium starts. So pink
Starts.
fibers of the myometrium, you can very well visualize if your
Correct. And
distension is clean.
especially if you've also given vasopressin, right? So there is a clear demarcation a lot of times
Yeah.
when
Yes.
you are, yeah.
So
See, the whole funda of myomectomy is you should not reduce your pressure. Okay, you go with the high pressure and try to finish within that pressure because the number of time you remove your resectoscope, go in, then there will be a lot of blood and clots. Then you again waste your saline to remove that blood and clot. Half of the
Correct.
saline will again go into that. And that is a
Correct.
vicious cycle. You will never get a good vision. So as
Correct.
far as possible, once you are inside, try to complete the myomectomy. Okay, and then come out. So that is
Correct.
how it will help.
that's a very important point because if you keep on removing the resectoscope out and then trying to remove the chips, then not only you're losing your pressure, but also there will be a bleeder and also your vision is also totally lost.
Totally lost. And the chance of air embolism also increases because of the negative suction,
Yes.
negative vacuum, what is created by you remove and pushing. You know,
Only time when you can reduce the pressure is like don't remove the scope, reduce the pressure and just be there to see whether there is any other small fibroid, the invisible fibroids are there coming out when you reduce the pressure.
today I did another
We done
submucous fibroid, where the fibroid was G1 type. So superficial part we removed. So we reduced the pressure.
that.
And
Then
then
we
intramyometrial part will pop inside. So you reduce pressure and you try to finish that also.
that and
Luckily, this patient was with laparoscopy. So initially, we just injected vasopressin in the myometrium. So when you reduce the pressure, there won't be any bleeding. That is the beauty of
yeah.
injecting
Correct.
vasopressin in uterine muscle. Okay, because when you want to reduce the pressure and you want that fibroid to pop inside, generally, whenever you reduce the pressure, the bleeding will start, and you will not be able
Correct.
to see. So once you injected vasopressin, even if you reduce the pressure, the fibroid will pop in, but there won't be any blood.
But that is only when it's associated with a laparoscopic
Laparoscopy, or
procedure.
else you can inject paracervical.
Intracervical.
Paracervical, I will not inject at 3 and 9 o'clock position where there is a descending cervix. I'll inject at 11 and 2 o'clock position,
4
little
and
above.
11,
So,
4,
you
7.
are a little bit in the safe zone.
and how much do we inject?
It's same diluted 20 units in 200 ml, and you can inject
Volume.
5 ml.
Okay.
Madam, in uterus we inject so much. So why we
Yeah.
are worried injecting from below? It should be same.
It's only the dilution which is important.
And not to hit a vessel.
Nah, not to hit the vessel. So select 11 and 2 o'clock, which is
Yeah.
safe, and you can inject nicely.
So I think it was a very good session, very, very productive. So I would like to, can we close? Have we cleared all the questions? Can we just check?
Yes. There
Okay.
is this.
Whether hysteroscopy can be done while there are some discharge.
Yes.
Yes, should not be a problem.
Because we are going to do a thorough cleaning and all those things.
What
And
I suggest is just, you can do open the outflow. If you are suspecting like our case of pus, we keep outflow open.
yeah.
Okay,
So
whenever you suspect infection, you keep the outflow open so that there is a continuous flow of the water and it will, flush out all the infection.
yes, for biometric.
Yes, biometric is.
Yeah. So all the questions we have answered, and can we
Can
do?
we do hysteroscopy on day 3 and 4?
Day
Yes, you can do. Ideally, you should avoid, but you can do with outflow open. It will clear up your cavity.
Yeah. So especially if you want to do it prior to your IVF procedures, you can do it. Okay, so fine. Thank you so much, all our history faculty, for a great presentation and for a very knowledgeable session, in fact. So it's our privilege from IAG to have you all in this very important webinar. And of course, office hysteroscopy, as we see, is no longer just a procedure. It is main key pillar for all our gynecological patients. And when well performed, we know that it transforms it into a very minimal morbidity with not much of a complications. Now we are not able to see many fluid overload complications because we are able to handle them appropriately, and we know how to avoid it also. And also today our focus was mainly to streamline the techniques and also the safety part, and also push the level of excellence in these hysteroscopic surgeries. So I would like to thank all our esteemed faculty, our speakers, our coordinators, our chairpersons for being part of this collective learning. And I thank IAGE for giving me this opportunity to continue this and conduct the program on Scope and Troca series. So this is the 7th series for this year, and we'll meet again in the next episode, which would be on the first week of January. So I would like also to take this opportunity to thank Shield Pharma, Sahiti especially, for a very seamless transmission. So Dr. Sujal Munshi sir has Dr. Sujal Munshi sir has joined? No. Is he there?
No, sir was telling that he won't be able to attend.
So
Ma'am, you can proceed with the vote of thanks.
thank you so much, all of you, and thank you so much, Dr. Shield Pharma also, for this wonderful platform. So we see you all in the next meeting, next webinar in Jan. Thank you so much.
Thank you so much.
Thank
Thank
you,
you.
ma'am.
Thank you so
Thank
much.
you, Dr. Mala. And it was nice. I mean, learning.
Yeah, it was
learning
a
for me.
wonderful webinar.
Yeah, excellent.
Yeah,
Excellent.
thank you.
Looking
All the
forward,
faculty did
looking
a
forward to more
wonderful
such
job.
webinars.
Yeah. So every month, first week we meet, sir.
I think there were nearly 140, 150 participants I could
We
see.
touched
That was good.
140. Yes, we crossed 140. Hi,
Yes,
sir. Hi,
yes,
Piyush
yes,
this
yes.
side.
Hi, Piyush.
Couldn't get the time to see me talk to you.
Kajal, hi.
Thank
Hi,
you.
sir.